Dr. Roberts, as you know, is the first urologist in the Bahamas and a transplant surgeon. He returned home in 1987 after having done after having done his training in urology and transplant surgery at Dalhousie University. And since then, he's done so many things, become head of the Department of Surgery, involved in family planning. He's presently involved in the National Health Insurance program, married with 2 children. And Dr. Roberts, we welcome you, and we will wait to hear your talk.
Oh, great. Okay. So you mean I can start now?
Yes, sir.
Oh, wonderful. Okay. Good evening, everyone.
Good evening, Doc.
Great.
Good evening.
You'll see from my slide, it says prostate cancer in the Bahamas, us too, the Bahamas chapter. So I want to talk about prostate cancer in the Bahamas.
Recording in progress.
And highlight the work of the Us Too movement of the Cancer Society of the Bahamas. September is the month designated to make the country aware of the high burden of prostate cancer in the Bahamas. First, treating prostate cancer is extremely expensive. Secondly, it is a leading cause of pain and suffering and death in the country from cancer. And both are compounded by the fact that the majority of people in this country, when they present with prostate cancer, present with advanced disease. So the die has been cast. And so it's against this background that I want to tell you about the Us Too story in the Bahamas and our endeavors to try and change these statistics. Now, I want to start by recognizing up front one of the major goals in treating prostate cancer is early detection if we are going to reduce the burden of this disease. And I want us to have a clear and true understanding of what we mean by screening. First and foremost, it's about early detection, detecting the disease before it spreads and the person is actually quite healthy. It is for the whole population, so the test needs to be safe. We had healthy people. It needs to be simple to do and inexpensive and practically no side effects. But it also, we want to make sure that when we test someone, that if cancer is present, the test is positive all the time. And when it's not present, that the test is truly negative all the time. But the most important feature I want you to recognize about screening is that if you are picking up the disease early, we expect that down the road, less people will die. So to see a decrease in the death rate from prostate cancer is a pivotal point, a very significant factor in the screening. And I want you to bear that in mind for later on. So why screening? Well, the best example of a screening test is the Pap test for women in terms of detecting early cancer of the cervix. That is the opening of the womb. Now, in the early 50s, one of the leading causes of deaths throughout the world in women from prostate cancer was cervical cancer. And then we got introduced to the Pap test. And I want you to see on this slide how when women came early for their screening for cervical cancer having a Pap test, you can see how the death rate plummeted over the ensuing years. In fact, today, no woman should be dying of cervical cancer. Cervical cancer today is a totally preventable disease. And it is so sad that in this country, it remains to be one of the leading causes of death in women from cancer. And it's because they're not coming to be screened. And so when we looked at the great improvement and the decrease in the mortality from the screening and Pap test, we had hoped that when we introduce a good screening test for prostate cancer, that we would see the same thing. So we said, why not? I remember one of my mentors saying, why not have a Pap test for men? And what he meant was to palpate a prostate. And so you get your prostate examination palpated, and at the same time, you'll have your blood test, the PSA for the prostate for early detection of prostate cancer in the blood. Now, so what happened with the introduction of the PSA test? Well, while this might be a slide, I found this in 2008, it really depicts what we're seeing today, because we see about 150 to 200 men who die a year in the Bahamas from prostate cancer. And we also look at the statistics and we see that men who die from cancers, that prostate cancer account for like 1 in 3 men who die. So it's extremely common. Now, let us look at the same time what happened in the United States when we introduced the PSA blood test. Well, within 10 years, there was a 40% decrease in men dying from prostate cancer. And not only that, they recognized that in men who presented with prostate cancer for the first time, that they had a 75% reduction in men presenting with advanced and metastatic prostate cancer. So this was revolutionary from that perspective. But what do we see in the Bahamas over that same 10-year period? We actually saw that the death rate increased over that same 10-year period, as if the PSA never existed. In other words, the men were not coming forward to get screened. And so, hence, we have the Us Too movement. And, you know, from this very humble beginning that we have, that the men realize, well, listen, why all this focus on women? The breast cancer, the cervical cancer. So the men stood up and they said, well, what about us? Us men too need to be made aware, to be educated and supported. And we need to lobby on our behalf with regards to prostate cancer. And hence the name Us Too. So in this international organization, which was formed in the United States in 1990, and it proliferated throughout the country. And finally, in 2001, I think we were able to have the first chapter of Us Too formed in the Bahamas. And this is the focus of Us Too: awareness of prostate cancer, to educate the men, to advocate for greater health measures, and to support men who had prostate cancer. We focus on early detection, and with the hope that with the early detection and our mission, that we would save more lives, we'd have a better quality of life, we'd decrease suffering, and we'd decrease men in pain and dying from prostate cancer. This is a gem. It shows you our first chapter president, Clyde Bettel, our second chapter president, Mr. Vince Ferguson, and I wondered what happened to Barry. But then he told me he was taking the picture, so he couldn't be in it at that time. But you can see some other giants and men. We have Pratt, and we have our famous printer who unfortunately passed away, I think, last year. And so the Us Too group became very interested in doing their annual prostate cancer screening. And so we chose the month of September, which was diagnosed internationally as the prostate cancer month. And we focused on we got the government clinics. The government gave us 4 community clinics. We decided to introduce this testing at no charge. And we wanted to find a time when men would be available, not to work. So we took the evenings between 6 o'clock to 9 o'clock. And we had our 4 clinics, one in the north, one in the east, one in the south, and one in the west. And Us Too, they were the volunteers. They organized the whole clinic, booking the clinic, getting the men to come. The providers, that is the physicians, and we volunteered our services, as well as all the other helpers inside the clinic, all the assistants in the clinic. I felt very strongly in the beginning that we wanted to have experienced physicians and doctors, and they would do the rectal examination. We'd know what we were feeling for. And then we did the blood test for the PSA at the same time. The Cancer Society initially donated kits. Now we think we have a fair amount of people who would donate to us. So I think we've tried to take that burden off the Cancer Society. We have the blood bank volunteers who they were phlebotomists, free of charge. And then the hospital, doctor's hospital as well as the PMH, they did the tests free of charge. And this is our sideburns when we first started. When I first started in 92, but our first formal clinic really was in 2004 with the Us Two group. And this really put it where it was like we were chasing after the man and say, please come and get your prostate checked. And we went out and we marketed. We went on the television, on news time, on talk shows, on documentaries. We gave lectures at churches, at NGOs, wherever we were invited. We had flyers out on the street. We went onto social media. We went on the radio and talk shows. We had free ads as well. And in the newspapers, editorials and articles. And what did we, and the men came. This was when our first clinic, I started doing a screening in the early 90s. I was really interested because the first screening clinic I remember vividly, I think it was in 91, in which I joined the Cancer Society doing a cervical cancer screening, doing the pap test. And I was there the whole Saturday, and I think 2 men came. But I was helping them out doing the pap test, which I hadn't done for medical school. But slowly but surely, once we started, the men started to come, and you can see the numbers increasing. We had a peak year, but then we're still trying to keep momentum. So in 2018, we are looking at averaging somewhere between 600 to 700 men in Nassau, and that's what we're trying to keep it at. And so the struggle continues. Of course, you don't see the 19 and the 20 because of the pandemic. I wanted to put this up here, and this is why whenever I give a talk, I don't mind if there are only women in the room, because we asked the men, why did they come? And what they will tell you is that well, they heard the advertisements on the radio or the TV, but their spouse or their male friends, 1 in 3 of them came because they told them to come. In fact, I've had women who brought their spouses or their better half, and they've actually come in the room and they say, Doc, I want to make sure he's here. I want to see that you're doing the examination. You know, we have the men who, you know, a fair amount of them do come back, 1 in 3, at least in 5 years. So we are seeing some outcomes that we want. Here is a sad part, because when we look at what should happen when you get screened, you got a blood test. Some blood tests need to be repeated. And then, or if you find that there was a positive rectal examination, you want to do a biopsy. And then if they're positive, you want to treat them. Well, unfortunately, in Nassau, the resources that we have in terms of the Us Two and in terms of the medical services, we inform the men of their results, and we expect that they will have a repeat, come and have a repeat. Sometimes I would do a free clinic just for men to repeat their exam and repeat their blood tests. But then they have to pay for it this time. And then there are those who need the biopsy. We're still waiting for them to come. And then, of course, if they make it, we can treat them. So it's challenging to follow up in terms of who should do it, when should the time, and can they afford it? So this is a disadvantage when you screen people. You must also follow up to ensure that they will come and you can get the expected outcomes. Else it's all for naught. And so we decided at Us Two that the time had come to spread out and move into the Family Islands. So the next site that we moved into, of course, was Freeport, our major city. Freeport has taken off. I think they also won some international award for the work that they've done. And this is showing you that very diligent board, and they are at a press conference and announcing their September screening. And so they have been very diligent, as you will see, in terms of getting the men out. And so when we started our prostate cancer screening clinic in Freeport, we again had the month of September, but we felt that because of the population size, we only needed one government community clinic. And like in Nassau, we wanted to have no charge. And we felt we only needed a day and a half. So we started on a Friday evening from 4 to 8. And on Saturday, we went all day from 8 o'clock in the morning until 4 o'clock in the afternoon. And the advantage in Freeport, because it's a smaller community and the people are more knit, the Us Two group really took off. And not only did they interested in the screening part of it and informing the men, but they also informed them, those who needed to have repeat tests. They made sure they came to see me and follow up. I had special I go to Freeport and do a clinic once a month, and I would carve out a period in which the men who were screened can come and see me at no charge. And those who, in their repeat blood tests, if they needed to have a biopsy, they got a biopsy. I was very thankful to Mr. Brown when he was the managing director, because for all practical purposes, he said if they were screened, he treated them as public patients. And so they got a free, I had my biopsy machine, and they also got a free biopsy. And for all practical purposes, their biopsy was done by the RAN at no charge to them. And then they joined the public system if they needed treatment. So the men in Freeport were committed. They made the time. They ensured that the care and the follow-up, the men accessed it, and it was affordable. And they came. They did better than Nassau. And you can see this progressive increase. In fact, I'm so saddened by Dorian because we were on a roll. In 2018, when we had our last clinic, in that day and a half, we saw over 800 men who came to get their screening. In fact, we felt so good about our clinic in terms of our follow-up and the work of the Us Two. We wrote a paper and it was published. And almost every other week, I'm getting a request for reprints. And we published a paper on the prostate cancer screening clinic in the Bahamas as a model for low and middle income countries. So we're very proud of the work that our Us Two group of men are doing. I just want to show you where we think we are going, because we started in 2012, and in the first 4 years, we had almost 2,000 total patient visits. We diagnosed 40 men to have prostate cancer. After 45, we diagnosed a very interesting algorithm in which we selected men who we felt needed to have their prostate cancer checked, needed to have their prostates. Let me slip back. That men who having a positive blood test or biopsy, we selected who we should treat based on their age, based on their state of health, based on their fitness for surgery. So we had quite a series of criteria as to what we should apply. And lo and behold, our predictive rate of positivity went up to almost 80% compared to the 30% of the literature. And so of the 40 men who are positive, what I want you to notice here in this first group, that 50%, 40%, so 90% of the men were found to have intermediate to advanced disease. So for all practical purposes, it's as if 90% of them presented with advanced disease. And when only 4 we felt were low enough that we could cure. And when we look at the ensuing 3 years, where now we had over 4,000 patient visits, we had an additional 27 patients. For the first time, we're starting to see an increase in men who are at low risk, and we're seeing a significant decrease in men who are at high risk. So we believe that we are making inroads, because when we see this number of over 4,000 men that came for a checkup for their annual screening, and you consider that there are almost 40,000 men in the northern Bahamas, I'm looking at Freeport specifically, who would be 40,000 of them being men. And if you look at the age specific group, those men who would be between 40 to 70 that you would want to screen, we have really touched almost 25% of the population for screening. That is phenomenal. And I really want to applaud the work of us too, in terms of getting the men out in Freeport and in terms of getting the annual screening. I want to emphasize this point because this changed the direction and how we screen our men. Because while we say that prostate cancer is the #1 cause of men dying from cancer in general, if we look at the cause overall of men dying, you will see that it only represents 3%. 1 in 3 men die from heart disease, cardiovascular disease, hypertension, and diabetes. And so we felt that we can't just stick with prostate cancer. We need to expand our clinic and look at these non-communicable diseases. So now what we have done in Nassau, as well as what we have done in Freeport, we now have a nursing volunteer team that come out, and we also have the Ministry of Health team that come out, provide this free service, where those men who come to be screened, we look at their weight, we do their waist circumference, we check their cholesterol, we measure their blood pressure, and we do their glucose, all at no cost in terms of advancing their healthcare. So we're very proud of the work that we're doing in us too. And here was a real jump up. We recognize that in the Bahamas, in women, our #1 cancer is breast cancer. And we've also been able to, through our research, found that one of the major causes of this breast cancer in women is an abnormal gene, the BRCA1 and BRCA2 genes. We have a gene mutation. And some 1 in 5 women who have breast cancer, they got it because of the genetic mutation. And what we've also come to find is that this same mutation gene might also be responsible for prostate cancer. Or another way of looking at it too is that we always thought that the daughters inherited their abnormal gene from the mother. They might have inherited from the father. And so we became interested in looking at this abnormal gene or this mutated gene in our men with prostate cancer. So the year before Dorian, we got a grant from one of our consortium, and we started to do testing for the BRCA gene mutation in 2018. And we were looking to do a study of 100 men, and unfortunately we had done 50 so far, and then Dorian came. So that's how we are expanding our clinic, moving it into a men's clinic so that we would be able to improve the health of our men in the Bahamas. And we think through our continuing and annual clinics that we will get the men to change their health-seeking behavior. This is something I'm very proud of. That when I went and had a discussion with the executive management team of the Princess Margaret Hospital, and I told them that we were interested in looking at these BRCA gene mutations in men, but we realized that if we were going to take on this responsibility, we also needed to have genetic counseling. And so they volunteered to have some of their oncology nurses who would be prepared to be trained in genetic counseling. And we had the support of Marathon Bahamas and Sunshine Insurance to fund the training. And so we had 3 of our nurses that flew up to one of the most eminent cancer centers in Philadelphia, Fox Chase Cancer Center. And they did their training in genetic counseling. And so we are ready to continue our project. So this is Monique Forbes here, who this is when she was doing her stent, and then she was followed by Nurse Kalfani, and then we had Raquel Johnson. And so us too and our movement to improve the health of men continues. So what are the take-home messages I would like for you to have? Because first of all, I wanted you to see that the men are doing their part. I'm very pleased with the work that we have of the Us Too movement, and I felt that a lot of people in the Bahamas, and particularly those who are in the in the Cancer Society are unaware of the great work that's being done and the successes we've had. So the first thing I want them to appreciate is that Black men get prostate cancer. It is more aggressive. It occurs at an earlier stage, and men under the age of 50. It is men who are obese, which is very high in the Bahamas. Some 2 out of our 3 men now obese. They are at a higher risk. They present with higher PSAs. They're less likely to get screened. They have longer intervals between screening. Most of them never get screened. I wanted to show that, and this is the evidence. This is from the US, and this is mimic anywhere where we have a Black society, that here are the African Americans compared to all the other racial groups, that you can see that Black men stand out at least some 3-4 times higher in terms of the death rate from prostate cancer. And in the Caribbean, you can see that looking at the mortality rates, this is the global CAN data for the entire world, looking at the country, the Caribbean tops right there. #1 country for mortality from prostate cancer in the world, in which 70 to 80% of our men present for the first time with advanced disease. And that's why we're doing it. And so the second lesson as to why we die from prostate cancer is because when it starts, there are no symptoms. I always want to repeat that. They look healthy. And that's when we want to diagnose our prostate cancer, because we feel that's when we can cure prostate cancer. Just wanted to show you why it is so important to come early. And this little diagram here, just wanted to show you it's a cutoff, as if we did a diagram of, this is the bladder. And let me see if I can, this is our men with the bladder passing through the urethra and the penis. And here's the prostate sitting to the bottom of the bladder. I was trying to show a finger that we can examine the prostate. That's the only way you can examine it. And here is the start in the first stage of a prostate cancer. It is so small that you can't feel it. It's just millimeters in size, just like the start of a woman having a breast cancer. That's why you do the mammogram, because you can't feel it and you don't want to feel it. You want to pick it up that early because that's when you can cure it. That's exactly why we want to do the PSA, so that you could detect this early rise in PSA, and that's when you want to pick up a cancer that you can cure it. But if you don't get a checkup annually, that cancer grows. So now it's at stage 2, where it is bigger, it's easier to feel. You have no symptoms because the urine is coming through clearly. It doesn't hurt, just like a breast lump. And then it progresses to the 3rd stage. Now it's starting to obstruct the passage, and you will not be able to void without some symptoms. So when you now present with symptoms, because you can't pee, or because you're peeing too fast, or because you see blood in the urine, it's too late. You now have stage 3 disease. And this is current some 5 to 10 years later. So that is the reason why we're looking at the early detection, because we see too many of our men who are presenting where the disease now has progressed to the 4th stage and it is spread and it's become metastatic. So early diagnosis presents a cure. Now, this is a discussion for another day. Suffice to say that we have a whole line of how to treatment. It's the most difficult decision to make. Whether you're going to have surgery, major surgery, nerve-sparing surgery, pinhole surgery, or whether you're going to have radiation and all the new fancy types of radiation. What is important is that whether you get surgery or radiation, it depends on the individual, but the results are the same in terms of getting rid of the prostate cancer or in terms of living longer. It's a choice. There are some men who come to me and they say, "Doc, I don't want to have cancer in me, cut it out." And then there are some men who come to me and they say, "Doc, listen, they say when you cut open the cancer, it spreads. I don't want no cut. I don't want no surgery." And so you have to know your patient. You have to know what their likes and dislikes and their personality. You have to sit down and talk to the family and let them make a decision of what they would like to do. There are newer procedures that are out. These are still in the experimental stage. You're getting good results, but they're not considered the full standard of care. What I want to point out, is that if you pick up the prostate cancer early, what we have come to realize is that prostate cancer is a very slow growing cancer. It takes 10 and 15 years to show itself. So if you got someone who's in their 60s or their 70s, the prostate cancer grows so slowly that it might never affect them. So what we have talked about now is that we don't need to treat them. We can watch them, but you have to be very careful. You have to actively watch them. They have to come and get their blood test checked every year. You might have to get their X-rays repeated. You might have to biopsy them and to make sure there's no spread of the cancer. And so this active surveillance has now moved center stage, where that almost half of the men who present with early prostate cancer are just having active surveillance. And the beauty of that is that they are not having any of the side effects that you have when you have surgery or radiation, which completely changes the lifestyle in some men. And many of them regret that they actually had it done. So if you become advanced, we have had some great advances as well. We have found that prostate cancer now, with the advances that we have, that prostate cancer is more like HIV disease. That we have some excellent new medications, which we didn't have 10, 15 years ago, and whereby we can prolong the life of men with prostate cancer, even advanced disease. And we have new drugs. So at one phase, the other one, we have a new one that can put the disease back into prolapse. So there are some great advances happening, but it's expensive. It's not cheap. You're looking at medications that can cost you $5,000 a month, $10,000 a month. You're looking at a vaccine that they are trying to put onto the market that seems to have some benefit. Costs almost $100,000, one shot. The chemotherapy, and it costs you at least about almost $20,000. And there's a new set of chemotherapy for the advances at $48,000. There's radiation for spread to the bones. You're looking at almost $70,000. So prevention is better than cure. We cannot afford to treat advanced prostate cancer. We have to go through the stage of having early detection and diagnosis. I want to leave this to this is a slide I always like to show people who have seen me done a presentation. I like to imprint this in your mind. Prostate cancer is no respecter of your status in society, your education, or the money that you have. These are all Black Caribbean men. Remember, I showed you that we have the highest death rate in the world. This is Michael Manley. This is Lyndon. This is George Mack. You remember these three Bahamians? They all died of prostate cancer, presented with advanced disease. And here's the same African origin, Sidney Poitier and Belafonte and Colin Powell. They all also were diagnosed with prostate cancer, but with early disease, and they're still alive. So the message is there. Early detection saves lives. So what can you do? You should have your annual PSA and your digital rectal exam. You should start at 40 years of age. And we believe that at the age of 70, that if you are having no symptoms, and if your PSA is normal and your prostate feels normal, there's no need to continue your annual screening with a PSA blood test. So bear that in mind. I see a lot of men who come for their checkups in their 70s and so on. I have no problem with continuing that, but the guidelines today suggest that that might not be necessary. There's a lot of commotion in terms of the PSA blood test. Now, it's the best thing we've got. But the truth of the matter is that it is far from perfect. We've realized that there are quite a number of things that can cause your blood test to be elevated that has nothing to do with cancer. All men, as they grow older, when you reach the age of 40, the prostate starts to grow. It's the only thing in our body that starts to grow. And it grows continuously, all men. Some men, they grow only to the size of a sour lime. Some men grow to the size of a grapefruit. But it will grow. But it's nothing to do with cancer. But a bigger prostate gives you a higher PSA. As you get older, then you'll also find that your PSA gradually increases. Again, nothing to do with cancer. Every time you have sex, when you ejaculate, if you were to do your PSA, within the first 2 to 3 days, it causes your PSA to go up. So you should always wait at least or have no sex for 3 days before the test. I like to say 3 instead of 2, so you're not cutting it close, that you would wait before getting your PSA blood test. If you have an infection in the prostate, and you can have an infection without any symptoms, and the infection has nothing to do with sexually transmitted disease. The same bugs that get in your skin are the same bugs that get inside the urethra and get into the prostate. And it causes your PSA to be up. You can, any infection in the urine, any infection anywhere in the urine system can cause your PSA to be up. If the doctor examines the prostate too hard, if you had any instrumentation, such as you had a look in the bladder, all of those things can cause your PSA to go up. That has nothing to do with prostate cancer. And if your PSA, let's say 4 is upper limit of normal, between 4 and 10, if your PSA is elevated, it's only a 15% chance it's probably prostate cancer. 85% is more likely to due to one of these. So bear that in mind, men. Do not get anxious if your PSA is increased. I need to add that big controversy. Should you have your PSA or not? Well, the problem that we had with PSA was that it was picking up these early disease. The men had no symptoms. They're quite healthy. A lot of those prostate cancer diseases that we now treat with active surveillance would never have brought it to men. But we picked it up early. We treated them. Major complications. Most of them lost their sexual function. A significant number of them had to wear diapers or pads. Their whole life changed. A fair amount of them, the cancer even came back. And so the United States Preventive Task Force in October 2011 said, listen, you are doing more harm than good. You should not get your PSA as an annual screening test. And that confused everyone. And they stopped doing it. Well, 5-6 years later, we realized the men started to come back with advanced disease, metastatic disease, and started to die of prostate cancer. So they revised their rating and said, it's not as bad as we thought it is. Yes, at least some moderate certainty that the net benefit is small. The key is, this is America. This is where men are going and they're getting their regular checkups. Not in our country. The men are not going. They're presenting with advanced disease. And so we need to, until we reach where America is, because they've gone through the stage where the men are getting their annual checkups, getting their PSA blood test, getting their rectal exam. So I urge and encourage that we need to continue to do that until we get those results. Final one I want to talk about is digital exam. You know, men in the Bahamas, I have a magical finger. I say all the time that the men feel that when I touch them, they're gonna change their whole lifestyle, and some of them might even become homosexuals. Nothing of the sort. They think that this digital exam is the worst thing that ever happened. Listen, the problem is a lot of doctors don't like doing prostate exam. It is an uncomfortable exam, but literally lasts just fractions of a second. So if you see the doctor there for a minute, you got to be very careful. It shouldn't last long. It's uncomfortable.
But the time is then.
So, but now there is evidence to show very clearly that a combination of the rectal examination and the PSA blood test will give the best yield. But there's also evidence suggesting today that you might not need the blood test because the PSA is so accurate. And so there is a move whereby they're saying, listen, you don't need to do the PSA. I mean, you don't need to do the rectal exam. Just come and get your PSA. I think that at the end of the day, we need to encourage our men to get their annual checkups. And that should include getting a digital exam because there's more than just the prostate that we want to examine. Very few men have ever seen their anus. It's not inspected. So when you go to the doctor should inspect that region. There are other diseases in the rectum other than prostate. There's rectal cancer. There are other infections. So that orifice is a very important part that needs to be inspected, and men should get used to knowing that this is all a part of their physical evaluation. I believe that every orifice should be inspected. And so We also want to make note that we have this nice new MRI is now being seen as a screening test, but goodness gracious, it's very expensive. And it's so it's going to be a long way before it reaches to the level whereby we can routinely look at men who and tell them that they should have an MRI screening. But what is clear is that in men whose PSA is elevated and their prostate feels normal, and you want to avoid getting a biopsy, these are the men who should be recommended to have an MRI screening to see if there is an image of a prostate cancer that can better direct your MSI. So I want to leave you with the fact that we need to have our men change their health-seeking habits. We no longer need to look at health as a state of physical and mental well-being. It's okay to say, yeah, I'm free of disease. What you want, though, is you want to move to wellness. You want to lead a lifestyle that will keep you healthy. And so wellness, unlike health, wellness is a lifestyle approach. It's something where you do, it becomes your habit, okay? And you actively do because you want to be in the best state of health. And the key about wellness is that it underlines that your health is your personal responsibility. You are the one that should be going to get checkup. You are the ones that want to ensure what your blood results are. You are the ones that want to look at your nutritional status and your physical fitness. Because we've also shown that a good state of nutrition, particularly a plant-based diet and physical fitness, has definitely shown that in men who have prostate cancer, that it decreases the recurrence of the prostate cancer and it decreases the progression of the prostate cancer in men. So I really want to encourage men who have prostate cancer that definitely wellness should be an active part of what they do. My last slide, I really want you to appreciate, this is Grand Bahamas. This is our 2018 last clinic that we have. This is Saturday morning. It is 7 o'clock. The clinic starts at 8. Here is the line on the right-hand side. The men are lined up and they are waiting to get inside. We haven't opened the doors yet. We have definitely made a major impact in the men's habit and their approach towards their health. So when we talk about, it's in a culture that men don't want to go see the doctor, I say foolishness. I believe that if men are made aware, that they would take the interest to better their health. I don't believe it has anything to do with a rectal examination, because they line up and they come and they have a big joke about it because they feel good about themselves and having it done. And having 803 men in 1.5 days speak volume about our Bahamian men and their desire to improve in their healthcare services. And so with that, I would entertain any questions that you'd like to have or like to ask me.
Hello.
Thank you, Robert. Dr. Robert, that's an interesting talk. Can you comment on some of the factors you think that have the Grand Bahamian men seek to come to the clinic versus ones in the Providence?
I think it has to do with a smaller society. So families are closer together. I think they have communities, still have communities where, unlike in Nassau, people live out the suburbs and so forth. You still have communities, and you have an us two society. You know, you have the leadership, and in particular, I must highlight Mr. Don Mitchell, who is a prostate cancer survivor, that he has taken a personal interest in ensuring that the data is kept safe and secure and compiled. He calls the men and he calls on the other us two men to make sure that the men are informed. He calls and singles out the men who need to have a repeat follow-up. and more importantly, he has been able to get those labs who that do the PSA screening, that when the men have the repeat PSA, that they get a significantly reduced cost, some 75% decrease in getting their PSA. And so I think all of this together, it adds to this change in behavior in the men with regards to getting their prostate cancer checked.
Can I make
Go
a
ahead.
comment, please?
Go ahead, sorry.
Yes, I just wanted to say that.
Oh, that's fun.
Yes, it is.
Okay.
Our clinics in Grand Bahama are Fridays and Saturdays, and Fridays they start at 4. The men are there from 11 a.m. Saturdays, we try to get there before them every year. We try to get them to get there before them because they always argue about who is first and who is second. They're now showing up at 3 a.m. on a Saturday morning, and we don't start until 8, which I think is amazing. And just to add to what Dr. Roberts said, since October of last year, because they have been chasing us all over Grand Bahama, asking us about the screening, we have quietly screened about 500, almost 500 men between October and now, even today, for the PSA, very quietly. We have them go directly to the labs because we say, which is, I'll name the 2 labs, Lucayan Medical and Medical Pavilion, who give us the preferred rate that Dr. Roberts mentioned, which is now available to all of the us 2 men who go to these labs. They go to one of those labs because the labs already have the protocols in place that we could not possibly manage if we had a clinic like this one that's on the screen here. So, and also Dr. Roberts has been coming. I think we've had now 8 or 9 clinics for those among these 400 to 500 men who have had high PSA or concerns. So we're still operating quietly behind the scenes here in Grand Bahama.
There's some other questions here in the chat, Dr. Roberts, I'll ask you.
Okay.
There's a question from a Facebook viewer. What impact does our diet in the Bahamas have on the prevalence of prostate cancer?
I think our diet has a very high impact. There's great experimental evidence of the effect of diabetes. I mean, the effect of obesity on prostate cancer. And I was always interested in the epidemiological data. And one of the studies that we were taught in medical school that holds true is that when you look at countries where they have a high plant-based diet, like in Okinawa, the clinical presentation of men with prostate cancer or dying from prostate cancer is extremely low, as compared to the same population, the same Chinese population that were in America, where the diet is different. And what they find is that if they migrated from Japan into the US and they changed their diet to that of the US, then their incidence of prostate cancer and the death rate in prostate cancer increases. We've also had experimental evidence whereby in the lab, if you implant prostate cancer on mice and feed them a high-fat diet, the prostate cancer grows. And the reverse happens when the prostate cancer, when you feed them a more vegetarian-based diet. So the experimental evidence and the inflammatory changes that we get in men with obesity, there's very good evidence that that's a major risk factor. And so I really would say that prostate cancer truly is reaching the rank of one of our non-communicable diseases. And we have a population where, as I said, 2/3 of our men are obese. One time ago, it was the women that were ahead of us, and now we are toe-to-toe with them. And I have no doubt that this is one of the underlying genetic factors that are underlying determinants of our health care.
Here's another question from a viewer with a PSA of, I don't know if the number is correct, but they put 380.4, but I think it's 38 to 40. And the government urology clinics closed. How can further testing or attention be given?
It is very sad because for most, over 70% of the population, the government service provides their healthcare services, only access they have to healthcare. I switch for a minute and put on my national health insurance cap and say that I encourage all the men to sign up for their national health insurance so that they can have a physician at no charge to them. Right now, the pandemic has created havoc in our healthcare system, and these men that need attention can't get it. I can only say that I can only speak for myself and say that I have quite a number of patients who have come to me from the hospital, the government-based services, and I see them and I treat them at no charge. So I'm not advocating to come to my office, but just to say that if they find their way to my office, I treat them and, at no charge, and with the hope that very soon the government services will open.
Okay, a lot of comments saying such a great presentation and great work, Dr. Roberts. Also, too, there's comments on great work by Mr. Mitchell in Grand Bahama, and kudos to him as well.
I see that Wendell Barry is on the line. He is our chapter president here in the Bahamas, and let me tell you, he works very hard, and he gives me all the data that he calculates by hand. It's unphenomenal, but I really want to commend him. He's one of our founding members and continues to push through. So hello, Barry.
Hello, Doc.
In terms of more exposure to men in New Providence, I hear your kudos, and I take my hat off to the people in Grand Bahama on the work they've done to date and the success they've had. I want to try and think outside the box on how to improve the care or the exposure we give to the men in New Providence, because this seems to be a problem here in New Providence. How can we change that paradigm to get the results you have in Grand Bahama here in New Providence?
I want to say this, that when we have our screening clinic in Grand Bahama, I just kind of fill in.
I hear you. I know, yeah.
The physicians at the RAN, they come and they volunteer their services and their time. And so I'm just there. As I like to say, I'm part of the team. In the Bahamas, we have not been that successful in getting the physicians to come out.
Nassau.
Yeah, Nassau. I have to take the blame for some of that initially, because in the beginning, it takes a fair amount of expertise to examine a prostate and to know what is normal and what's abnormal. So I set the stage whereby I wanted senior physicians to be doing the rectal examination. And on most of the occasions, I got them. I have Dr. Evans would come out to at least one or two of the clinics. Get Dr. Stevens to come, Dr. Mbala would come, Francis to come. But I guess the time has come that we need to make a appeal to the broader physician group. We've got the Doctors Association, we've got the Medical Association, we've got the union. So maybe I will take a point from Barry. I know that he has invited them before. So it's not that we haven't been trying to invite them, but we will continue to double our efforts for them to be a part.
Okay. Any other questions from the group? May have another question here. Any other questions?
I see Don has his hand raised.
Go ahead.
You have to unmute him.
I don't know how to do that.
Yeah, unmute. Yeah, he needs.
Aaron,
Which
can you unmute him?
Don Cartwright or Don
No.
Mitchell?
Sorry, yeah, okay, can you hear me now?
Yes, we can.
Good. Okay, I'd like to acknowledge the presence in this chat of Dr. Pedican, Mandy Pedican, and Dr. Tankawan, who are the pathologists at the RAND in Grand Bahama, who do all of our biopsies and so timely with returning the results to us every time on time. And I'd like to say that in Grand Bahama, Dr. Roberts talking about the smaller community. It's more tightly knit. We've been able to make private arrangements with the private sector for cost savings for the men to go to these labs almost at will. I'm wondering if you could have a parallel situation, perhaps in Nassau, out of the goodness of their heart. And this is why they do it. They don't have to do it, but they offer 70-80% discount. I wonder if something like that, if Barry, who came up here at the beginning when we started us two and helped us to get going, Randall, I wonder if we could have parallel, similar relationships, arrangements in Nassau like we have in Grand Bahama, so that we could continue to move in Nassau, because the costs are very low and they are controlled.
Yeah, I think we gotta take some pages out of your book and try and adopt some of your plan that have worked well for you in Grand Bahama. So we'll get in touch and we try and mimic some of those things you've been doing very well in Grand Bahama.
Thank you. We'd be happy to share.
Okay, great.
I want to say hello to my two pathologists in Grand Bahama. I didn't notice that they were on the chat group. Glad that you joined us. We couldn't do what we do if we didn't have them along and being a part of the team. Thank you, Mandy. Thank you, my other good Adavan.
Dr. Roberts says a thank you from the Us Two group in Freeport. They say they appreciate you very much and you've done a lot of good work there. Are there any other questions? So as you know, this month is prostate month, but you know, the pandemic is on us and we have also an election upon us as well. So we'll have to see what we can do even beyond September to try and promote screening and healthy lifestyles to try and bring down the rate of prostate cancer. Next month is breast cancer, and you know, breast cancer always gets a lot of press. So at some point, maybe in the future, we're going to get prostate cancer almost on par with the breast cancer groups. So we always will continue to try and help do that aspect of it. So any other questions at all for Dr. Roberts? Or there's a comment saying, it's also the consistency of Don in the work in Freeport. So thanks to Don as well. Don't want to miss him out.
I think our chapter leader was here as well, Avril Mortimer.
Okay, yes, he was here earlier, right?
And
okay,
one of our very, very hardworking Us Two members and a survivor, Kenny Basin, is also in this chat.
Okay, welcome.
Okay. Right, he's here.
Are there any other questions at all? Anybody at all?
I just wanted to make a comment. I saw that just in case, you know, you say they were a PSA treaty. Let me tell you something. I have men who come to me with PSAs in the thousands. Okay, that just to show you how advanced the disease is. I want you to see I'm wearing my Us Two shirt tonight, eh? No, I just wanted to show off before you leave. All right.
Very good. Are there any other questions? Dr. Roberts, I thank you.
Okay.
And I think we will meet sometime to try and strategize more what's the next phase of things to do, you know?
Okay, great.
If no other questions, again, the announcements for the Cancer Society next month is Breast Cancer Month, and we'll have a slate of activities to put on for the month, and stay tuned for our agenda. But next month, the second Tuesday of the month, we're going to have another monthly meeting and a special speaker on breast cancer itself. So stay tuned for our announcements, and I hope to see you again next month at our monthly meeting, as well as participating in the other events for next month. And I bid you good night.
Good night.